We're stuck in a world of health insurance benefit designs from the 1960s. Fundamentally, it hasn't changed much in terms of structures of deductibles, co-pays, prior auth, and so on.
We're looking at the overall systematic impacts of the IRA to patient access, and will patients be able to see a new therapy for their condition, a better therapy for their condition? Will they be able to afford that therapy? And will they be able to access that therapy ultimately? And I think that is a real challenge in this space. We know that the rare ecosystem is extremely sensitive. Any disincentives that exist will result in fewer therapies being developed.
Unfortunately, this act is really moving us into a direction of less efficiency and higher prices. This is pushing us towards an environment where there's going to be less competition and more attempts at going into smaller markets that won't be affected as much by the Inflation Reduction Act.
The whole idea here is to reduce cost, to shift money from Medicare to other places. But who's going to carry the burden? It's going to be the payers, and how are they going to recoup their money? They're going to take it out on the patients. Medicare patients have paid hundreds of thousands of dollars into the system over, a lifetime. Get to the system, and what do they get? Well, they get fewer drug options and less access to those drugs.
A price cut alone isn't going to generate the savings the government is potentially counting on. Instead, Medicare is going to have to achieve these savings through reductions in utilization, and that means reducing patient access. The drivers of this price setting are largely at odds with other administration priorities like the Cancer Moonshot, the Orphan Drug Act, which is widely supported in Congress.
Previous Congressional Budget Office estimations for direct negotiation to work properly, you have to have a reduction in utilization, right? You just have to cut access, and it can be as much as 26% in one of the reports showed, and that was considered a conservative estimate.
If there's anything in the pipeline that has an IRA exposure, then typically that bill might be abandoned.
So we have to assume that every single drug is affected by this. The natural reaction is going to be to clamp down on the access to those drugs that are no longer profitable. And in particular, while I think the out-of-pocket cap is great, an out-of-pocket cap with no complementary formulary oversight is going to be a disaster for patients. They're just going to find other ways other than cost barriers to keep patients from getting those medicines.
If there's a disease that primarily impacts older Americans, like colorectal cancer, you're going to see less innovation for that, even though it impacts a reasonably significant amount of younger Americans.
For CMS, I hope they understand they have an opportunity to signal what value is in this context by rewarding companies that innovate and produce better, more effective therapies for their communities, that they will be rewarded if that product is selected for negotiation.
One thing we would like legislators to know is that there is not one answer to any of these conditions that we work with. There is not one solution, there is not one prescription, there is not one drug, there is not one therapy. Being able to say that you addressed diabetes, a rare disease, a heart condition, does not solve diabetes, rare disease, or heart condition.
It is really important that these decisions are being made now. And therefore, the time is now to address some of these shortcomings that we see that have been pretty clearly defined now by the CMS guidance.
Just remember, it's more than a list. It's every single drug in Medicare.
I don't view healthcare as a commodity. I don't view prescriptions as a commodity, yet we treat it like pork bellies. And I think that's a big, big problem in this country, is to keep in mind that we're dealing with people's lives and quality of life.
Having the opportunity for multiple options and multiple therapies really is what's keeping people alive until the next innovation comes along. And if we don't have that anymore, then people are facing some pretty dire consequences.